Topic which has been allocated to me is post-Kasai issues in biliary atresia. As we all know that biliary atresia is one of the commonest conditions or causes of neonatal cholestasis, but now we are basically recognizing multiple subtypes. One is the syndromic biliary atresia, which has got the basum malformation, and we need to know this because they are at a much higher risk of developing hepatopulmonary syndrome as compared to the common garden biliary atresia. Then we have the CMV associated biliary atresia, which has got a predominant role of inflammation, and now there is an upcoming role of treatment for the CMV and improving the results. Then we have a cystic biliary atresia, where if antenatal ultrasounds are done, it can be detected much earlier, and so these patients may have a better outcome because of the early age of detection and surgery offered. And then the isolated biliary atresia, which is by far the majority, but still a very heterogeneous group. Over the last 2 decades, at least in the Western world, the outcome of biliary atresia has improved, and with or without transplant, we have nearly about 75 to 80% 20-year survival. It is, as we all know, I think biliary atresia is a lifelong disease, and that's a very important thing when we counsel these patients that a Kasai portoenterostomy is not going to cure the child. So the parents need to identify that. And all efforts, as we have discussed, is that our target is that we make an early diagnosis, do a very good surgery, so that we can have a successful Kasai portoenterostomy. Because a successful Kasai will change the outcome for the child. After the Kasai portoenterostomy, which is the topic which I have to cover, is that we have to try to detect the complications early, offer prompt therapy for complications, maintain good nutrition, which I'll be covering in detail, and then timely consider for the liver transplant. And most of the patients, as in the next talk it would be discussed, would need a liver transplant either because a primary liver transplant because the child presented late, or after a Kasai portoenterostomy, whether it is failed or successful. The failed ones would require it much earlier as compared to the successful one. So what are the main post-Kasai portoenterostomy issues? One is cholangitis and intrahepatic bile aches, portal hypertension, pulmonary complications including hepatopulmonary, portopulmonary, cirrhotic cardiomyopathy, hepatic hydrothorax, issues related to nutrition and bone health, cognition, risk of hepatocellular carcinoma, development of various other complications of liver failure. And then obviously we need to prevent secondary insults by infections, by alcohol as they mature into adolescent and young adults. So what is the role of steroids? Can we improve the rates of Kasai? Because we all know that our target is that we want to have a successful Kasai portoenterostomy. So multiple studies have been done, and the meta-analysis of 7 studies, it basically showed that there is an increase of 10 to 15% extra clearance of jaundice in those infants who are operated before 70 days of age and those who have given a high dose of steroids. Now this extra dose, does it really translate, or extra clearance of jaundice, does this really translate into a better native liver survival? This is the data from the King's College, where they have shown that if you go even younger, as we have discussed, in those babies who are operated before 45 days of life and who are given a high dose of prednisolone, that's 5 milligram per kg, there the native liver survival has shown a significant improvement. So the younger the baby, the earlier the surgery, and we give a high dose steroid, now we are able to show that there may be an improvement with this high dose of steroids. Again, this is a study from China where they had 380 biliary atresia patients, and they showed that the 2-year native liver survival with high dose steroids was much higher as compared to the low dose steroid. But contrary to these 2 studies, in this 2021, this is a study from Singapore, where they showed that there is no difference in the rate of cholangitis or native liver survival, whether you give a low dose steroid or you give a high dose steroid. So I would say the jury is not out, but yes, there is a trend that in the babies where we are able to operate earlier, there may be a role of high dose steroids. It has been clearly shown that the age at Kasai portoenterostomy, presence of fibrosis, liver stiffness measurement at 3 months, whether the baby had an episode of cholangitis within 3 months, and the jaundice clearance time. If you put these 5 factors in a nomogram, you can see what is the probability of native liver survival at 2 years. So these are the main risk factors which are going to predict the outcome, and all these of them would be known to us by 3 months of age, and we can very easily say whether this child is going to require or not require a liver transplant. Now, going to the first and most important complication is of cholangitis, which is seen roughly in about 50 to 90%. It's mostly in the first 2 years, and as we all know, we suspect it when there is fever, increase in jaundice, or the stools become pale, and there is signs of sepsis. What is recommended is that we have to try to prevent the early cholangitis, which is within the first month of life, because this has been shown to predict a prolonged jaundice clearance time. It increases the risk of recurrent cholangitis, and there is a very poor native liver survival. So and the second thing which increases the risk of cholangitis is when the babies develop intrahepatic cystic lesions post Kasai portoenterostomy. And it has been clearly shown that the earlier they develop, if they develop these cysts within 3 months, there is a much poorer native liver survival of 40% in comparison to those who are developing it 6 months after the portoenterostomy. So we need to monitor for these intrahepatic cystic lesions if we want to prognosticate or manage our patients better. Then, even in the long-term survivors, even in those patients who are living for more than 20 years with the native liver, it has been clearly shown that the patients who had late cholangitis required liver transplant much more often. So cholangitis is a very bad thing for these children with biliary atresia, and we need to make an effort to prevent or treat them early. So what can we do? We need to have a high index of suspicion in any febrile episode. Obviously, we'll need to treat it with IV fluids, antipyretics, antibiotic. There's a very small subgroup where in a very good braining anictoric child, there is sudden onset of cholangitis. There may be a possibility of a rule loop obstruction. I think the people here are much more expert in looking at it as compared to me. And this is a very small group. There might be a role of a revision surgery. After the antibiotics, obviously, if the patient is going on with cholangitis, there's a role of ultrasound-guided drainage of abscesses and a PTCD for the bile lakes. And we should monitor for the intrahepatic cystic lesions at least within the 6 months after Kasai so as to predict the outcome. Now, is there any role of prophylactic antibiotics? Various people have used antibiotics like Septran, cephalosporin, quinolones, neomycin. But whom to treat? Should we treat only the ones who are having recurrent cholangitis, early cholangitis, or the ones with the bile lakes? Or should we treat all? There is no answer. How long should we treat? Should we treat it for 6 months, or should we treat it for 12 months, or should we treat it for 1 month? There is again no answer in the literature. The systemic review of 319 cases there and 1 randomized control trial showed contradictory results. But it has been shown that prophylactic antibiotic use is again associated with increased transplant-free survival. And most of the people believe that because cholangitis maximum episodes occur in 1 year, so if you are giving them antibiotics, it might be prudent to give it for a year. And definitely the babies who are developing early cholangitis or recurrent cholangitis or who are developing bile cysts, those patients definitely need prophylactic antibiotics. Now going on to portal hypertension. Portal hypertension is a complication which is present in the vast majority of children with Kasai's portoenterostomy. Obviously, most of them have splenomegaly at diagnosis. In fact, 70% of them have high portal pressures even at the time of surgery. We recently had a patient whom we shifted for Kasai portoenterostomy, and 2 days before the surgery, this child had a variceal bleed and was found to have grade 3 varices at 2 months of age. So it is a very common problem, and these patients can have ascites, variceal bleed, and higher risk of varices is there, and that also bleeding from the varices in patients who had failed Kasai rather than successful. And again, portal hypertension in a large study has been shown increases the risk of developing cholangitis. So these two most important complications are interlinked with each other. Nearly 75% of the babies post Kasai will develop varices. Nearly 30% of them will bleed. And bleeding usually is beyond 6 to 9 months of age, but obviously some small subgroup can bleed earlier. And various methods have been used to non-invasively predict these varices, because we can't keep on doing endoscopies at 3 months, 6 months, 9 months. So platelet count, there are multiple formulae which have been used based on the platelet count, spleen size, albumin, and AST, which we all do routinely in our evaluation of these patients, to non-invasively predict the varices, and they have a nearly modest efficacy, about 80 to 70%, along with the measurement of the liver stiffness at various time points, whether it is at the time of 1 week after Kasai portoenterostomy or 3 months, but these are useful to predict presence of high-grade varices, and they should be incorporated in our algorithm when we are following these patients. So management-wise, what we would suggest is that surveillance endoscopy can be done at 6 months in a patient who's having a failed Kasai, around 6 to 9 months. In those who are successful, I would say around 1 to 1.5 years of age, and then they can be given treatment. Those who have got high-grade varices can be given prophylactic treatment. Variceal bleed has to be managed standard management, which we all do, along with antibiotics, that is endoscopic therapy. Endocytis obviously has to be managed, and splenic, if there is hypersplenism, then splenic embolization can be considered. Now, there are lots of pulmonary issues in patients with biliary atresia, and most important of them are hepatopulmonary syndrome, portopulmonary hypertension, and cirrhotic cardiomyopathy. Of roughly around 5 to 8% of biliary atresia patients also have coexisting congenital heart disease, which also needs to be tackled. So for the hepatopulmonary syndrome, the children may be asymptomatic, or they may have clubbing and cyanosis, so we should look for it when they are coming in follow-up. And a very simple test might be just to check their pulse ox saturation. If it is more than 96% and there's no clubbing or cyanosis, we can say with reasonable accuracy that our child does not have hepatopulmonary syndrome. If we are suspecting, it is seen in roughly about 4 to 64% patients of biliary atresia, much higher for some unknown reason in those children who have got the biliary atresia splenic malformation. And to diagnose, we have to do a blood gas followed by a saline agitated echocardiography, which will help us make the diagnosis. Why is it important? Because once the child has developed hepatopulmonary syndrome, you have to, for mandatory reasons, consider him for liver transplant. There is no other treatment for hepatopulmonary syndrome. The second complication is of portopulmonary hypertension, which is basically pulmonary hypertension in the presence of portal hypertension. These children may present to you with just exertional dyspnea, and that would be diagnosed by echocardiography, which shows that there is high portal artery pressure, and then you have to do a right heart catheterization. We can try medical management like sildenafil, epoprostenol, but these are all again not going to work wonders, and we have to offer early transplant provided the pulmonary artery pressures are within reasonable limits. If it goes beyond 40, 45, then even a transplant might be a contraindication. Hepatocellular carcinomas are seen in about 1% of children with biliary atresia, and they are many a times picked up in the explanted livers. Liver ultrasound and alpha-fetoprotein should be done every 6 months when we are following these patients. And sometimes the problem here might be that these patients have a lot of focal nodular hyperplasia, which may be misdiagnosed, and alpha-fetoprotein may be normal. Therefore, if there is any suspicious lesion and you have repeated an ultrasound and it's increasing in size, we should do a prompt evaluation with a CT angio, because that will pick up your HCC quickly. And again, because all patients have end-stage liver disease at the time these children are picked up, again, liver transplant is the only viable treatment if you're picking up HCC. Now, coming to nutrition, obviously that's the most important parameter, because either both the outcome of the child as such as well as the post-transplant outcome depends upon the nutrition. So we have to give them adequate calories because they are cholestatic. We give them medium chain triglyceride supplementation. We give them fat-soluble vitamins and calcium. Need to remember that metabolic bone disease causing fractures with minimal trauma is common in these patients, even if they are not jaundiced. And so there might be a recommendation to do a bone densitometry every 5 years and detect early Osteopenia. If a small subset develops pruritus, we manage them. The basin patients, definitely you have to make sure that they are getting the pneumococcus and meningococcus vaccines because they are immunocompromised and they have higher risk. And in any other child also, we would make an attempt to do a routine and extended vaccines for these patients. And we need to educate them as they are going towards puberty about avoiding alcohol, hepatotoxic drug, and IV drugs because they will increase the chances of getting further liver injury. So how do we do this post-Kasai screening? I would recommend that we do a liver function test, hemogram every 3 to 6 months. We assess for cholangitis. We do ultrasound for bile lakes. We do a screening endoscopy depending upon the success of Kasai at 12 months or 6 months earlier if the patient is not doing well. We offer prophylactic endotherapy. We screen for HPS by measuring the saturation every visit and ABG once a year. An alpha-fetoprotein and an ultrasound every 6 to 12 months. We monitor their growth and we do their vitamin D status and bone scan as and when required depending upon the clinical status. Now, after talking about what we need to do, what is the real world scenario? This is a recent study where they surveyed the European centers, including UK, who performed the Kasai portoenterostomy, and the jaundice clearance rates varied from 30% to more than 60%. And there was no consensus on what is a standard adjuvant drug treatment regimen that you will offer to the children once they have undergone a Kasai portoenterostomy. Steroids were given by 60% of the centers, but again, variable dose and duration, which could range from 4 weeks to 6 months, but on an average about 3 months. Only 20% would repeat a course of steroid with a bad cholangitis, but none were wanting to give repeated courses of steroids for treatment of cholangitis or refractory cholangitis. Perioperative antibiotics were given by all centers, and most of them favored piperacillin, tazobactam, and gentamicin for a variable period of 1 to 2 weeks. Prophylactic antibiotics were given by 70%, again, roughly around 6 months, but again, it varied from 1 month to a year, and Septron was used most often, followed by cephalosporins. UDCA was given by 100% of the centers, and few centers still continue to use phenobarb and cholestyramine. Testing for viral serology to detect the CMV positive group was done by majority, 70% of the centers, but only half of them believed in giving antiviral therapy to those who were CMV positive. None were using IVIG or any herbal or traditional Chinese medication. So to conclude, I would like to say that biliary atresia patients need lifelong monitoring on a regular basis with either I would say with a team of hepatologist and surgeon together. Clearance of jaundice is the objective metric to judge the efficacy of the Kasai portoenterostomy, and we all should make an effort to diagnose them as early as possible and offer surgery as early as possible, because that's the only factor. Early diagnosis and surgery by expert, which would improve the success of Kasai portoenterostomy, especially because failed Kasai portoenterostomy has a universally poor outcome. Complications like ascites, variceal bleed, and infection and cholangitis need prompt treatment. We use steroids, UDCA, and prophylactic antibiotics, but there's still no consensus on the duration. And early consideration for liver transplant will go a long way for improving the outcome. And we need more research and more randomized control trials so that we can say, okay, this is what works and this does not work to improve the outcome. Thank you very much.